Elaine Arkin, you may begin your conference.
Thank you so much, and I'll add my welcome to Rafi's. I'm Elaine Arkin. I'll be moderating the webinar today. Thank you all so much for joining us on a Monday. Today's program we're really excited about. It's a spotlight on the Childhood Obesity Declines project, which is published as a supplement by the journal Childhood Obesity. The presenters today will talk about the rationale for the project, the methods and findings, strategies, patterns, and commonalities, and implications for research and evaluation approaches. After they present, we'll have an opportunity. It's called one-on-one. That is our question and answer session. And finally, I'll give you just a few quick NCCOR announcements. So before we get started, before we get to our little intro, if you have if you need any technical assistance today, then please let us know using the chat box on the right. If you're having trouble logging into the webinar but can hear us on the phone, email us at ncor@fhi360.org. That's fhi360.org, and we'll work with you to resolve the problem. I know some of you were having a little bit of trouble hearing earlier, so if you're still having trouble with the volume, also if you would enter that into the chat box. And an important technical note, if you're listening to our webinar using your computer speakers, please turn down or mute your computer microphone. This will greatly reduce the potential for background noise. Now, if you have a question for our speakers during the webinar, please write it in the chat box because we will be taking those questions at the end of the presentations. And the best part of this conversation is based on the questions that you have. So please feel free to enter those. We will be live tweeting during the webinar if you're on Twitter or other social media programs. We encourage you to join the conversation using the hashtag here, ConnectExplore, and following at NCCOR on Twitter and at ncor.org on Facebook. Our speakers today, we're very grateful to have a group of authors from the Childhood Obesity Declines Project Supplement. We have Tina Kauh, Senior Program Officer at Robert Wood Johnson Foundation, Nicola Dawkins-Lyn, who's the Vice President for Public Health at ICF, Laura Kettel Khan, Senior Scientist and Advisor, Division of Nutrition, Physical Activity, and Obesity at CDC, and Deborah Young-Hyman, who is a Health Scientist Administrator at the Office of Behavioral and Social Sciences Research at NIH. And thanks so much to all of them for joining us. Now, quickly, before we get started, we have a very brief poll just to learn a little bit about you. Primarily, which area do you work in? If you would let us know, and we see you all clicking here. Okay, so research and program implementation these have the greatest representation, but a nice mix across the spectrum here. So thanks so much for this, and we are now ready to begin. And Tina, I will turn it over to you.
Great, thanks, Elaine. Good afternoon, everyone, or depending on where you're joining us from, good morning. Thank you for joining us today. I'll be kicking off the webinar by briefly describing the premise for the project and why NCCOR chose to support it. So before I begin, I want to point you all to the recently published series of papers that are the focus of today's webinar. These papers were published just a few weeks ago in a special supplemental issue of Childhood Obesity, which can be found on NCCOR's website, which is on this slide here. As I'm sure everyone on this webinar knows, the childhood obesity epidemic continues to be a critical health concern for our nation. Data from the most recent NHANES National Health and Nutrition Examination Survey indicate that nearly 1 in 5 U.S. children aged 2 to 19 had obesity in 2015 and 2016. Over the last 45 years, the percentage of children who are considered to have obesity more than tripled, rising from 5% to over 17%. And prevalence has been and continues to be even higher among those from African American and Hispanic backgrounds. And while there are limited data available for other ethnic racial groups, there is some evidence that rates are also high among Native American, Pacific Islander, and Southeast Asian American children. In response to these alarming rates, numerous strategies like policies, campaigns, programs, and changes to the built environment to increase healthy eating and physical activity have been implemented at the local, state, and federal levels to curb the epidemic. Potentially as a result of these broad efforts, signs of progress have popped up around the country, which you can see on this map. And in the past 5 years, more than 35 U.S. jurisdictions at the local or state levels have reported declines in obesity measures among some segment of their population. NCCOR initiated the Childhood Obesity Declines project because we wanted to learn from these communities, these signs of progress, to understand not only what strategies were being implemented there, but also to learn about what factors either facilitated or impeded the implementation of those strategies. We had 3 main objectives for the project at the outset. We wanted to systematically assess the evidence to verify where communities experienced statistically significant declines. Second, within those communities with verified declines, we selected 4 to do a deep dive to understand not only what strategies were implemented, but also how they were implemented, including factors that could have either impeded or facilitated the quality of implementation based on the perceptions of key stakeholders within each of those communities. And finally, given the striking disparities in childhood obesity rates that persist across ethnic racial groups, we initially hoped to understand how communities might have targeted their efforts toward high-risk populations to see reductions in disparities. Members of NCCOR initiated this project in 2014, and NCCOR represents the 4 largest funders of childhood obesity research, the CDC, NIH, USDA, and RWJF. And the project was led by a group of NCCOR advisors, some of whom you're hearing from on this webinar, and carried out by researchers at ICF International. The methodology and interpretation of findings was also guided by external advisors made up of experts in public health and research methodology. And guided by an adapted version of the systematic screening and assessment methodology, the project team identified 19 jurisdictions that had reported declines in childhood obesity rates at the time the study was initiated. And based on a set of exclusion and selection criteria that we developed, we selected 4 sites: Anchorage, Alaska, Granville County, North Carolina, New York City, and Philadelphia. And a significant amount of retrospective implementation data were collected through a range of data sources, including policy document scans, surveys, and interviews. And your next speaker, Nicola Dawkins-Lyn, will provide much more detail about the methodology and data collection efforts for this project.
Thank you so much, Tina. As a reminder to everyone, if you have a question, do type it in the chat box on the right of your screen, and we'll address it after our presentations. So at this point, I'd like to turn it over to Nicola.
Thank you so much, Elaine. Okay, well, as Tina mentioned, the study sought to explore factors that may have contributed to declines in childhood obesity in the selected locations. The study team first scanned popular media reports and peer-reviewed literature to identify sites that were reporting declines in rates of childhood obesity in the United States. And we then selected sites for case studies based on established criteria that I will review shortly. We reviewed site-provided as well as published documents to identify potentially relevant site-specific strategies. And then through snowball sampling, we identified key stakeholders at each location and administered a survey to identify whether various obesity prevention strategies took place during the examined time frame. Those were strategies that were recommended by groups such as the Centers for Disease Control and Prevention, the Health and Medicine Division of the National Academy of Medicine, or formerly the Institute of Medicine. And we also examined policy and contextual data for each site. And finally, we conducted site visits to interview respondents who were knowledgeable about the strategies across multiple settings. And the study really focuses on results from that last step, the site visit interviews about strategies that were implemented in the sites that had significant obesity declines. So this slide reflects the site selection criteria. We began the Childhood Obesity Decline study in 2014. And at that time, as Tina mentioned, a scan of popular media reports and published literature from 2010 to 2014 identified a total of 19 U.S. sites that were reporting declines in rates of childhood obesity. So to learn more about how sites may have been accomplishing this, we established criteria to select sites for our qualitative study. Data documenting the decline had to include children's height and weight that were measured objectively by trained staff. We also required a statistically significant decrease in rates of childhood obesity. And when needed, ICF team members obtained data from the site and conducted significance testing to assess statistical significance. There needed to be a minimum of 2 BMI data collection periods. That included baseline BMI no more than 10 years before the start of our study, so the 2003-2004 school year, and then follow-up BMI data no more than 5 years before the start of our study, so the 2008-2009 school year. And then ultimately, we selected 4 sites that met the selection criteria: Anchorage, Alaska, Granville, North Carolina, Philadelphia, Pennsylvania, and New York City. And you can see here the study sites, the ages or grades of children where the declines were found. And those ages ranged from ages 2 to 4 to children that were in schools with classes from kindergarten to 8th grade. And also shown in this table are the percent of the identified decline and the period during which the declines occurred. Okay, and here in this timeline, this diagram, we capture various interventions that we learned about in each of the 4 sites. We actually learned about many, many more than the ones that are included here, than the many that are already included here. But we highlighted in this timeline as what we call strategies for focus, those that were specifically targeting children in the age range where the declines were found. This diagram is included in the manuscript, so it can be reviewed there more closely. I'll just point out a few things. Here on the left, you'll see that in each of the sites, various interventions already were underway before the start of the period where the declines were found. The period where the declines were found, you can see in the center of the graphic, ranged from 2003 to 2011. And then in addition to interventions that were taking place in each site, some federal guidelines and policies also were implemented during this time, such as the reauthorization of the Federal WIC Act in 2004, the 2007 federal requirements for the Child and Adult Care Food Program, and the 2010 Healthy Hunger-Free Kids Act. And then finally, as noted there on the right, interventions continued to be implemented beyond the study period where, the specific declines were found. On the next few slides, I'll just share what we called the strategies of focus that directly targeted the age range of children where the declines in obesity rates were found in each of the sites. So in Anchorage, we learned about the Anchorage Municipal Child Care Licensing Revisions, which was a physical activity policy addressing the early care and education setting. Also, nutrition changes were made in the Anchorage School District, including a soda ban, a nutrition policy that addressed that school setting, and then the Health, Wellness, and Physical Education Initiative in the Anchorage School District was an initiative that included nutrition and physical activity programming and policy in the school setting. Next, in Granville County, we identified a child care nutrition initiative, a nutrition policy to prohibit things like sweetened beverages while increasing whole grains, for instance, in the early care and education setting. We also learned about the healthcare referral program, which was an initiative that included nutrition and physical activity programming and policy to assure screenings and yearly checkups in the healthcare setting, and the child care physical activity policy, which was implemented in Granville County in the early care and education setting. In New York City, we identified the New York City Food Standards, a nutrition policy that addressed all the settings. It involved comprehensive nutrition standards for all foods purchased and served by city agencies and their programs. Also, the school nutrition policies, including such things as removing whole milk from public schools while introducing lower fat and fat-free items, as well as salad bars and healthy vending. And the Move to Improve program, a physical activity program that was implemented in early care and education facilities and in schools in New York City. And finally, in Philadelphia, we identified the Universal Feeding Program pilot, which is a nutrition program and policy that broadly increased access to free and reduced price lunch in the school setting. Also in Philadelphia, they had during that time the Eat Right Now program, another large-scale nutrition program that provided nutrition education to students using SNAP-Ed funds in the school setting. Philadelphia also instituted a policy to ban sugary drinks in schools during this time, and they implemented a comprehensive district-wide school wellness policy that addressed nutrition and physical activity in schools with programming and policies such as switching from 2% to 1% in fat-free milk and banning the use of deep fryers. So in general, we might characterize the targeted nutrition-related strategies as including changes in nutrition standards in public schools, changes in nutrition standards in early care and education settings, comprehensive school wellness policies focused on nutrition and nutrition education. And then the targeted physical activity-related strategies included comprehensive school wellness policies, again, with physical activity focus components, classroom-based physical activity, early care and education physical activity licensing requirements, and then physical activity health education. And though each site was different, we did identify a few similarities in the ways that strategies were implemented. First, in each site, as I mentioned, we learned about a large number of initiatives that took place just before and during the period when the declines were found. And these efforts primarily addressed nutrition and took place in the community and school settings. Again, we highlighted here just the ones that targeted the populations of children that experienced the declines, which was primarily in the early care and education and school settings. But we learned about many, many more initiatives as well. Also, these sites tended to be early adopters, particularly of nutrition policies that later were mandated federally. So in most cases, those federal guidelines were reinforcing what was already occurring by increasing nutritional standards across the board. I'll also note that across all the sites, we heard that requirements could not be implemented without endorsement and participation from teachers and school administrators. And across the strategies, state or city officials such as governors and mayors, as well as leaders in the departments of health and education, such as superintendents and principals. All these sorts of individuals were reported as being instrumental in having served as champions in supporting these efforts. Some of the efforts that were attempted in some of these sites, like taxes on sugary drinks or some mayor's initiatives that were attempted, they may not have ultimately been successful in those sites, but respondents nevertheless described that they raised awareness in the community of issues that were related to improved diet and physical activity. And then finally, we learned that partnerships across multiple sectors were reported by all the sites. That included education, health, community, faith-based organizations. Some respondents described this feature of strategies being implemented across various sectors, across settings, across levels as a layering effect, where they believe that that layering effort improved their odds of reducing obesity rates in their communities. So I was able to share just a bit about the initiatives that were implemented in each of the sites covered in our manuscripts. But if you haven't already had the chance, I do encourage you to review the site-specific reports. They're available at this link on the NCCOR website. There you can see much more detail about what we learned in each of the sites, other initiatives, other strategies, methods that we applied beyond the what was collected from the site visit interviews, etc. With that, I will close and turn over to the next speaker.
Thank you so much, Nicola. And just before we turn it over, again, if you have a question, please add it to the chat box. We will have time to answer those. And as some of you have asked, we will archive this webinar, and you will get a notice once it's up on the site, so you can share the link with your coworkers. So with that, I will turn it over to Laura.
Thanks, Elaine. Good afternoon, everyone. This is Laura Kettel Khan from the CDC. Excuse me. Let me forward here. What I want to do is just share with you, Nicola just did a great job of overviewing all the, the wide variety of strategies and things that we observed in the 4 sites. But one of the things that we recognized in trying to summarize and document really what was happening is we saw lots of patterns and commonalities. And so on this first slide, I want to spend just a minute on it because one of the key pieces of evidence that we learned from this study is that the 4 communities have or had very similar patterns of prevention strategies, which Nicola kind of went over with you. But all these strategies that were used to influenced each level of the socio-ecological model as depicted here on the slide, and they involve a variety of the sectors within the communities. Many of us have kind of known or suspected that this is really what was needed all along, but we've really not mapped it out. We haven't, had extensive evidence of this or, data to document this for a long time. And so this study is the first time that we've at least tried to diagram it as a tool in our understanding of what's happening in these communities where we're seeing success. And so in this slide, it's a basic diagram of the socio-ecological model. It has the various layers in it, the individual first circle is in kind of like the pinky purple color down at the bottom, and then it, goes up to the interpersonal in kind of a purple, and then it has institutions and organizations, and then the community is out, further out from that, and then the systems and policies at the furthest level. But what I want you to think about when you look at this diagram aren't the layers only. I want you to think about it also in quadrants, or if you draw a line right in the middle of that circle, front, left to right, and then also right in the middle of the circle, top to bottom, so that you can see 4 quadrants. An upper left, in this, if you look on the upper left-hand side in that quadrant, you'll find for every single community there is a cluster of policy, system, and environment change interventions or strategies that are oftentimes focused at the state level or have some type of legislative or political driver behind them, such as an official task force or an alliance that focus on healthy eating and active living for obesity prevention. And then if you switch and go to the upper right-hand quadrant, these are clusters of community-wide programs that are food and physical activity or physical environment specific, such as healthy food financing initiatives, for the whole entire city, or complete streets that, include access to parks for physical activity. And then when you flip down to the lower side of the model, on the left-hand side and the right-hand side, the whole lower half, are setting specific, with the left-hand side our quadrant highlighting policies and programs that target breastfeeding support through hospital programs or early child education facilities, and the policies that those facilities can have for healthy food and physical activity. And then the lower right-hand side is the cluster of what is happening in that community's schools or school districts, programs, and policies. So that's just a general kind of orientation to these blue and purple circles. And so let me go to the next slide. There we go. And this is pretty small, but I want to walk you through it. And you can see this figure in the manuscripts if you want to get the detail. But comparing this particular slide is going to be comparing all 4 sites at the same time. And so you're kind of getting an overall look at them, what we're going to do, or what I'm going to walk you through, is an overlook at the 4 communities quadrant by quadrant. And so if we want to focus on the upper left quadrant of each of these communities, that's where the clusters, the state-level collaborations and work groups are, that are often, as I mentioned before, they're usually grounded in some type of legislation or political authority. For New York City, which is letter A, they have a state-mandated obesity prevention task force and a citywide school district advisory committee that supports their state legislative safe routes to school and farm to school / preschool program. And then for B, which is Granville County, it has a state legislative task force which supports their state and county-wide Eat Smart, Move More initiative. And that initiative leverages just a host of programs underneath it. And then letter C is Philadelphia, and it has the Urban Food Fitness Alliance, as well as a state-level community putting prevention to work, or what lots of us know as the CPPW program. And then finally for Anchorage, which is D, down in the right-hand lower corner, Anchorage has a state DHHS Healthy Futures initiative that worked in conjunction with the city's mayor's task force. And then let's move to the next quadrant. We're going to stay on the upper half of the circles. We're going to go to the right quadrants where we see the clusters of the more localized healthy eating and built environment efforts. So we're kind of going big, statewide initiative to the localized initiatives. For letter A, or New York City, we've got the citywide food retail expansion to support health initiative, or it's oftentimes called the Fresh Initiative. In Granville, in that same quadrant, was a county-wide Greenways Active Master Plan. In Philadelphia, which is letter C, they leveraged the state healthy food financing program to include they included Philly's Food Bucks and Health Farm to School programs. And then finally, in the D figure, when you look at that same quadrant, you'll see that in Anchorage, they had a municipal pedestrian bike and trail plan, as well as a state farm to school and preschool program. And then finally, what I want you to look at, and when you're looking at all four of these diagrams, or these four of these communities diagrams again, when you look at the lower left quadrant for all four sites, you'll see very specific targeted programs that support breastfeeding and early child education policies and programs. And then when you flip to the lower right quadrant, you'll see all the institutional policies and programs for schools. So just in sum, I want to just say that there's some very pointed patterns of success in all of these communities, whether they were big metropolitan cities such as New York City and Philadelphia, or if they were rural communities such as Anchorage in Alaska and a county in North Carolina such as Granville. It is not that other locations around the country couldn't be mapped fairly closely to what we've seen in this study, but what we're learning is that at a minimum that that if we are to have a chance at impacting obesity at the population level, all the various levels of the socio-ecologic model have to be included, and the multi-sectors need to be engaged in that effort to see any kind of success. So again, if you have any questions, Elaine will walk you through that process.
Sure. And Laura, could you, I'm going to go back just quickly because
Sure.
There's one question that I think we should just answer now. And Julie was asking if you could please repeat what the 4 quadrants in each chart represent.
Sure. Let me go back just to make sure I'll just say it exactly how I wrote it.
I'm going to show the big one, so.
Okay. Remember, let's go to the upper 2 quadrants first. The upper left is policy, system, and environmental interventions at the state level and or have some type of legislative or political driver behind them, such as a formal task force, a legislatively mandated task force, or some kind of alliance at the state level. The upper right-hand quadrant are more generally community-wide programs that focus on food and physical activity or the built environment. And they're not setting specific. But then if you flip to the bottom half, on the left-hand side, we put all the early, young child initiatives, such as breastfeeding in hospitals, and or anything that's in the early child education setting. And then on the right-hand side, same thing, anything related to the policies and initiatives at the school or school district level. Does that answer your question?
Yes, thank you so much. And again, if you have questions, then please type them in to the right here, and we, as you can tell, are monitoring those, and we'll be able to answer them after Deborah speaks. So, Deborah, I'm going to turn it over to you now.
Thank you. Good afternoon, everybody. I'm going to shift focus a little bit and talk about the implications for research and evaluation approaches of the Childhood Obesity Declines project. Just to be clear, I'm going to take kind of a high-level overview in this presentation and talk about, from a research and evaluation point of view, why did we use systematic screening and an assessment method, and the needs for a mixed method approach to evaluate natural experiments, comparing SSA methods with other evaluation schemas, and the integration of SSA-based evidence with other evaluation-generated evidence, talking about implications for future research program and policy evaluation, and then finally the importance of using stakeholder collaboratives, in this particular instance the NCCOR model. So what does SSA uniquely capture or differentially capture from more traditional evaluation schemas? In the absence of a priori evaluation schema, and these locations did not necessarily have an evaluation schema, evidence that is currently available can be identified, evaluated, and compiled to inform decisions regarding obesity prevention and treatment. SSA identified the social determinants of health of the targeted population, and I actually noticed that there was a comment that it was interesting that it wasn't provision of health that seemed to be associated with declines. It identified contextual characteristics of the settings and what community-based resources were used to achieve these outcomes. Why is it important for using mixed method approaches in natural experiments? So for the purposes of the paper and for this effort, we adopted the definition of the Medical Research Council as a natural experiment being a non-randomized, multi-level, community-based strategies, interventions, and programs which were examined post hoc, and importantly, wherein mechanisms were not manipulated by the researchers in this case being the evaluation team. What we did was combine statistically verified significant declines in the rate of childhood obesity in each of the targeted populations, which is a customary clinical trial outcome, a pre-post measure of your main outcome. And we temporally associated that with synergistic community-based programs and policies, as Nicola talked about earlier and Laura just described. SSA evaluation was grounded in the context in which the initiatives occurred. It was descriptive, it was process-focused, and temporally anchored. The primary data collected occurred through narrative. Identification of the key components thought to be successful in changing rates was informed by multiple stakeholders, including implementers. Convergent validity was utilized to establish a timeline of implementation. You see that in the timeline below, which is a much simplified version of the one you saw before. Implementation stories from multiple stakeholders identify the components, including leaders, champions, implementers, settings, and funders. So on this slide, you see again a high-level comparison of the SSA method and clinical trials evaluation. On the left is retrospective SSA, and here are the key take-homes I hope you will take from this, and you can certainly learn more from the paper in the supplement. Retrospective SSA is public health and stakeholder-driven and implemented. Efficacy is based on pre-post population statistics. There is no randomization, and the characteristics of the intended recipients are not restricted. Implementation components and setting characteristics are identified, and simultaneous contextual factors are described. These findings facilitate generalizability of methods, potential successful methods, but no attribution of causality is possible. In contrast, clinical trials are controlled experiments designed to answer a specific research question. Efficacy or effectiveness is based on the difference between a control and experimental group or a pre-post cohort analysis using highly specified participants and highly specified implementation conditions. External threats to validity are not controlled, and those are the simultaneous contextual factors I referenced. Therefore, the ability to attribute causality in a clinical trial is there, but results are of limited generalizability beyond the exact cohort and the exact implementation setting. Integration of the evidence from SSA with evidence from other evaluation strategies is essential to mixed methodologies. SSA identified the what, to who, by whom, and the social context, and identified elements of implementation that appear to be central to success, including the resources, champions, funders, access, and feasible settings, which you've heard a lot about already. When combined with a statistical change in the prevalence of obesity in the targeted population, this combined evidence facilitates case comparisons to identify likely strategies and resources that appear to be successful across venues and populations. Think about the quadrants that Laura pointed you to. What are the implications for future research, program implementation, and policy evaluation in this space? Although an a priori evaluation may not be in place for community-based natural experiments, in fact it usually is not, valuable information can be learned from unpacking of natural experiments. And although adapted SSA cannot make attributions of causality to specific programmatic components or policy implication for actual declines in childhood obesity, it provides the insight into potential targets for future community-based childhood obesity prevention efforts and research. And when formulating public health approaches to reduce rates of childhood obesity, contextual understanding increases the potential for generalizability across multiple settings and populations. Finally, what is the importance of research collaboration, in this case, NCCOR? COBD happened through the collaboration of NCCOR stakeholders. This working group contains members representing a unique partnership between the major funders of childhood obesity research in the U.S. As you heard, the CDC, NIH, Robert Wood Johnson Foundation, and the USDA all were represented. Each organization views the issue of childhood obesity through an agency-specific lens, and we all differ in our research and evaluation agendas, what we're looking at. However, in this collaborative effort, we looked at all of it. NCCOR recognizes as a model that traditional research and evaluation methods need to be augmented to address the complexities of the impact of community-based initiatives and policy implementation. That's very different than controlled experiments. And I will stop there, and I guess we're ready for questions.
Well, thank you so much, Deborah. And thanks also to Laura, Nicola, and Tina for your presentations. Again, here is an opportunity to ask questions if you haven't done that yet, and we will turn to the questions that we have seen in the chat box. Here's one from Lori. Was measuring BMI the primary healthcare strategy? And speakers, there was a little bit of a discussion in the chat box. A surprise that there wasn't more going on in the healthcare sector. So anyone want to take this one?
This is Nicola. I'd happy to take this one. So 2 points I'd like to make. One is that, again, we did identify in each of the sites other strategies that were implemented beyond the ones that I was highlighting in the timeline and discussed today. But again, the ones that we highlighted were the ones that were kind of specifically focused on the, in the settings and populations that experience the declines. So you will find, if you have the opportunity to go and take a look at the individual site reports, reference to some other, again, not much. So you all, it was interesting that you all noted that in the discussion, but you will find some other references to initiatives in the healthcare setting. The one that I highlighted, the healthcare referral program in Granville County, that involved, it did involve BMI screening. That was made yearly, kind of a formal yearly policy that sort of screening would take place for children, but it also involved educating parents about the importance of bringing their kids in for these checkups, and that these screenings would be a part of it, and it included education to providers about the importance of screening on BMI and having those conversations with parents.
So this is Deborah. I'd also like to add to that. In modeling of health health outcomes on population level statistics, one finds that only 10% of health outcome variability is in fact attributable to healthcare use. The remainder is based on social determinants of health, and this is a statistic that has been replicated a number of times now. And that's what gives this particular approach a lot of weight in terms of needing to access these other factors to know what they are and evaluate them.
Great. Thank you so much. We have a number of other questions coming in, so I'm going to move right along. There's a question from Wendy. Have declines in the 4 communities been consistent across all the years, or did they fluctuate, that is, go up and go down?
So this is Nicola. I can chime in on this one briefly as well. So in each of the sites, the rates had been increasing until the point where that baseline and then the subsequent decline that was statistically significant was found. In each of those cases, we did, when an additional year of data was available, we did look to see if the decline remained in that sort of additional year of data that was available, and it did. The declines did continue to hold in additional years, but certainly there may have been variations in like subpopulations within that broader group and that sort of thing. So certainly it's a bit more complex, right, than we're able to fully characterize here. But yes, once the statistically significant decline was established, we were able to confirm that decline held in a subsequent data collection.
Thank you so much. And I'm going to move on to a question from Sam, which is, was there a pattern in which of these quadrants developed their initiatives first, or were they implemented simultaneously?
This is Laura, and I'll jump in on that one. Sam, actually, you'd have to look at the individual timelines that were in Nicola's slide to see when different things happened. And quite frankly, the figures that I shared with you don't list every single activity that we found out was going on in the communities. We just highlighted some of the ones that seem most pertinent, just because they wouldn't fit. I mean, a lot of the communities, I mean, most of them had so many things going on that you just physically couldn't write them in. But they were often little offshoot kinds of, strategies and stuff like that were not very widely, it wouldn't have provided very wide exposure in the community. And so in terms of timing, no, it wasn't, I can answer it in the simplest way, no, it was not linear, and no, it was not planned. That's the other thing that I think, I don't think we've chimed in on this much today in today's presentation, is that even though we found this multitude of strategies at the various levels on the socio-ecological model and within all these different settings, oftentimes the initiatives were not done in coordination with each other. They just happened to happen at the same time. Some of the initiatives were aware of their, what we're going to call sister initiatives, but not all the time. This was not a singular planning, or a strategic planning for the community, and had things, working in conjunction, and that it was all kind of regulated and controlled. That is not what happened in these communities. These are truly natural time periods in which things just happened at various points in time and through various people's leadership.
Great. Thank you, Laura, but it worked.
Yeah.
Question here from Sharon, who's a physical education teacher. Did any of the schools have daily PE?
And this is Nicola. It's a great question, Sharon. And yes, yes, we did find that daily physical education was one strategy that was implemented in a number of the sites.
Okay, thank you. And again, referencing those great reports to find out more. And from Megan, did you try to quantify the dose or the exposure of the community members to the various interventions?
Either Nicola or I could take that question, but I really want to take the opportunity to say no.
Right.
The point is that this wasn't a controlled experiment. It wasn't monitored prospectively. These initiatives, as Laura was saying, were not planned. They weren't pre-planned and coordinated. It wasn't a manualized, codified set of interventions on any particular level. Even policy implementation has various level of penetration and financial support. But the importance is that dose and effectiveness of dose in any one of these potentially successful strategies should now be evaluated.
Thank you. Well, there are some wonderful questions coming in, but we're just about out of time. So keep those questions coming if you have them in the chat box, and we will answer them and send you a notification that we have talked to the speakers and they have prepared some answers. Some of these questions are fabulous and a little more complex than we can answer in the next minute or two, but we will provide answers. And I hope this has whetted your appetite to look at the project in more detail and the site-specific reports as well. It's you know, a lot happening in a community, even if it's not in lockstep, and all those 4 quadrants in these cases certainly has made a difference, and that layering that Laura has talked about has seemed to work in all of those cases. And as Deborah was discussing, this is a very different kind of research than some of us are used to, and so learning about these research methods, and there's a question about that as well here that we will answer later, is part of what NCCOR is trying to do. So again, thanks so much to all of our speakers. I just want to quickly, before we run out of time, give you a couple of highlights. NCCOR recently published a theme issue in the American Journal of Preventive Medicine that really describes NCCOR's structure, design, accomplishments, and lessons learned. So it's a great place to learn about what makes a collaborative tick and what you can accomplish that we think is useful on a community or a state as well as a federal level. The full issue is available on NCCOR's website. In addition, you'll find on the website NCCOR's 2018 annual report that highlights tools, resources, and communication efforts in 2017, as well as the work that NCCOR has done recently related to physical activity, which is a newer emphasis and a very strong emphasis for us right now. So, and some other tools you can use. NCCOR recently updated its catalog of surveillance systems. There are over 70 systems that have been updated with new data and information. And just to let you know, NCCOR is now opening a call for submission on new systems. The criteria are on the website. You can see the inclusion criteria here as well as the exclusion criteria. And we encourage you to go to the website for that. And if you have questions about NCCOR or upcoming activities, please email the NCCOR Coordinating Center at ncor@fhi360.org. And just a reminder, we're now on Facebook. Follow and like our page at ncor.org. Now, just to let you know, to access this webinar, use the top navigation and click Webinars, and all upcoming and archived webinars are displayed here. And again, you will get a notice when this one, today's, is uploaded, which will happen pretty quickly. And finally, thank you so much again to our guest speakers, Tina, Nicola, Laura, and Deborah, and to all of you who've taken time to be with us this afternoon. And before you sign off, can you just please take 1 minute to complete a brief survey, because it really helps shape our future webinars to make sure we make the best use of your time.